Thanks for coming to our health session. I'm Diane Enright. I'm the moderator. I work at the North Carolina State Center for Health Statistics. I manage the health and spatial analysis branch there, and I've been doing that for quite a while. I've been there for about 22 years. So GIS in Health is not new to me, but we have a great panel for you today. And I'm not going to do a bunch of introductions because I want them to speak about who they are and what they do as part of the discussion. So we'll just start it off. Joseph Sloop, he's with MAPS Forsyth, the city county. Then we have Jennifer Rankin, who's on the end, with HealthLandscapes. Philip Summers from Wake Forest School of Medicine. And then we have Lavette Miller, who's in epi and surveillance at Forsyth County. So I'm going to ask Joseph to say a little bit about what he does. Yeah. Are you on?
I do GIS.
You come up here, Joseph. There you go.
Can you hear me? Oh, yeah. Yes, okay. All right, so I'm Joseph Sloop. I'm the Geographic Information Officer for MAP Forsyth. So we are in Forsyth County, and we are an enterprise GIS department. We get to work with a lot of different municipalities throughout the county. And we also work with a lot of nonprofit groups located in our county. We're a unique GIS department in the fact that we don't do tax mapping or GIS planning and those kind of things. We do special projects. We do also take care of address points and center lines and those kind of things. That's really the only thing that we kind of do day in, day out. But everything else is really project driven. So like I said, we work with the public health department. We work with any department that does not have GIS staff. We kind of step in and help them. So lots of times you can kind of think of us almost like a vendor within the county. And so we're able to help with any and all departments. And like I said, we've been able to work with a lot of the nonprofits. Our county manager is a huge GIS champion. And basically he just told us go and do good things. And so he's made life a lot easier for us to be able to go and create partnerships with the different groups within our county.
Okay, great. So then we'll have Jennifer Rankin speak, and she's going to come up here because she has a few slides to share.
So wanted to thank you all for inviting me down. I am Jennifer Rankin. I'm with HealthLandscape, which is a division of the American Academy of Family Physicians. When HealthLandscape first was created, it was part of the Health Foundation of Greater Cincinnati, but from the inception, always worked with the American Academy of Family Physicians, and specifically with the Robert Graham Center. The Robert Graham Center is the policy division within the American Academy of Family Physicians. And from the beginning, when they were doing their health policy research, they've always had geography as part of the component of that research. And what they realized was they were doing some really interesting work. They were influencing people maybe in Washington, D.C., but that policy work wasn't being translated to something that the doctors out in the rest of the United States could really understand or use. And the best example I can give of that is some work that we had done related to payment policy on enhanced payment if you work in a health professional shortage area. So a lot of work was circulating around Washington, D.C., but if you're Dr. Smith on Main Street in the middle of Kansas, how do you know if you're working in a health professional shortage area and should be getting that bonus payment? And so they wanted to expand the research that they were doing into building online tools that would help people understand what was going on. The group at the Health Foundation eventually became known as HealthLandscape, and in 2007 we officially launched our first online platform, which was HealthLandscape version 1. It was a data repository for a lot of the social determinants of health information that everyone is using, but it also allowed you to upload your own data and share those data with the world if you wanted to. And because it started as this sort of love affair between the Health Foundation of Greater Cincinnati and the Academy, it sort of was bipolar. The Health Foundation wanted this data repository. They wanted this way for people to share their data with the world. And what the Graham Center really wanted were tools to help translate policy. And so when we first launched HealthLandscape version 1, it did sort of have this not a good feeling of where you should be going. You had to sort of know exactly what you were doing when you got there and find your way around. The two main tools were our Community Health View tool, which had all those data, and our Primary Care Atlas, which had that health professional shortage area tool, a physician scarcity tool, some information about where physicians had done their residencies, and a distribution tool. The work that we had done there led to a grant from the Macy Foundation, and they were really interested in looking at the social accountability of medical schools. So whenever you look at those U.S. News and reports rankings of medical schools, most of those rankings are based on how much grant funding they get for research from National Institutes of Health. There's no taking into account the sort of social mission of a medical school. Are they producing primary care doctors? Are they producing doctors that practice in rural areas? Are they producing doctors that go into health professional shortage areas, et cetera? And so we did a lot of research on that. We published some reports, and we built the Med School Mapper. It's still online, it's still available, but it has not been funded since that original grant, so it has not been updated. And this is the closest thing that still exists to the sort of middle point between HealthLandscape version 1 and HealthLandscape version 3, which I'll talk about in a little bit. But in this particular side, we're looking at the state of North Carolina. We're looking at counties in the United States, and we're looking at the red counties are where graduates from any medical school in North Carolina are practicing now, 1950 to 2009. And so we sort of see how well the state as a whole does in retaining the people that they're paying to train. We can see where people who aren't being retained in the state are practicing, and at the bottom we can get some sort of statistics and ranking. How well does the state do compared to other states in 6 main areas, whether or not primary care, rural, et cetera. You can also look state or school by school. So here we're looking at East Carolina University at the Brody Medical School, and we can see that they do a really good job of training people who stay in the state of North Carolina. And so this tool, like I said, looking at the social accountability, but it became a tool that people were using as both a legislative tool. You know, we're spending money in our state on these medical students and they're leaving the state. Is that something that we want to be doing? It became a recruiting tool. You can look county by county and see which medical schools provide the most doctors per county in the United States. And so if you're looking for a new doctor, you can say, look, you've got a lot of colleagues here that were trained at the same school. Why don't you come and look at our county? So the Med School Mapper was used in a variety of ways. Currently looking for funders to update it. So if you know anyone who wants to give us some money, we'd be happy to talk to them. But then, as I said, HealthLandscape as a platform continued to evolve. And so what we currently have online is what we're calling HealthLandscape version 3. And it allowed us to be more modular. So it allowed us to take, instead of having all the tools dumped into one place, we could take the tools and mix and match them for whatever purpose was needed. And so here we're looking at our original tool, Community Health View, that data set, or that data warehouse that had all of those social determinants of health information. And we can look at the information online. We can select a data set. We can search by keyword. And we can see even at the bottom, there's some limited functionality in terms of visualization within the tool. And that led us to update that residency footprinter that I was telling you about. So similar to the med school mapper, looking at family medicine residencies and where do the people that we train there, where do they end up practicing? And this tool had a very different purpose. Family medicine residencies are the first ones targeted when the budget starts running low because they don't bring in a lot of money. And so how do we figure out where our graduates are contributing to there not being a health professional shortage? And so what the Residency Footprinter does is allows us to simulate a shortage area. So if we say that there's a physician shortage, if there are fewer physicians than 1 per 2,000 people, those are all the orange counties. And then if we withdraw all the graduates from MAHEC, which is the residency program that I have selected here, the counties in red would become a shortage area if they didn't have the doctors that were produced by this residency program. So that's the purpose of the Residency Footprinter and how it's used. Looking further at physician training and education, looking at the GME Outcomes Mapper. So where we put in graduate medical education dollars, are we getting the types of physicians we're looking for? And this is just a filtering tool. So I'm looking for any residency here, and I'm sorry, I guess I need to invest in some readers. I'm looking at any residency that has had at least 300 graduates, with at least 20% of their graduates going into primary care, and at least 15% of their graduates practicing in rural areas. So you start with a very large number of programs and can filter down to those programs who are meeting those social mission areas. And lastly, on our workforce mappers, we have our primary care physician mapper, which we also have a version of this that we built for the American Medical Association, which is a health workforce mapper. The primary care physician mapper is obviously looking only at primary care. The AMA Health Workforce Mapper, which if you Google them, you can find that, looks at all physician specialties, and it also looks at non-physician providers. So where are the nurse practitioners located? Where are the physician assistants? And you can sort of see the distribution of physicians and non-physicians and compare them. You can do the side-by-side mapping. You can get a sense of where there's need and where there's not. All the work that we had done in those areas led us to HRSA, the Health Resources and Services Administration, and they were interested in taking their uniform data system, which is a data set that the federally funded health centers report into every year, and they wanted to use the data that were there in a mapping tool just for their project officers to look at service area overlap. So we as a federal government do not want to fund 2 programs serving the same area, or we want to minimize that as much as possible. Can we build a mapping tool to look at where patients are already coming from, where patients are not coming from, so we can make better funding decisions? The uniform data system itself, as I said, is reported by the Health Center Program grantees and the non-funded lookalikes. It's an annual data set. They just turned in their 2016 data on February 15th. They reported at the organization level, so even though they may have many sites, it's an organization level data set, so it has some limitations. Patients are reported by zip code because of data reporting requirements, reducing the data burden on the health centers. And the data that we have on income of patients is limited. We don't have that by zip code. So even though that's an important factor of the UDS mapper, we don't have that information. So we do have to make some estimates and guesses in the mapper, but that's the best data we have. When we launched the UDS mapper, we had a year to build it for about 100 users, and 6 months into the build, actually 4 months into the build, they came to us and said, actually, we want to open this up to the public, and we need it by May. So they lopped 3 months off of our development time. So when we launched the UDS mapper, we were still using the same data model for the use case that was the original use case, for project officers to look at these data. And so what you can see in the mapper and what we're seeing here is a comparison of the patient data to those underlying demographics. So here I'm looking at of the people who are low income, so below 200% of the federal poverty level, what percent of those people are going to any federally funded health center organization? So the darker the green, the better the health center program as a whole is doing in serving that target population. The lighter green shows there is potential room for growth of the health center program. The obvious limitation is I only have data in the UDS mapper from one safety net provider type, the health center program. So me, never having been to Raleigh in my life, I don't know if there are other safety net providers here that are meeting the need of those patients or if there's potential room for growth. But it's a tool now, since it's open to the public, that can be used for strategic planning and used for grant writing to help make the case of why I should have this federal grant or why I should have any grant. It's a tool that's being used broadly in the safety net arena. It's now required when you're applying for funding from the Bureau of Primary Health Care within HRSA. As I said, the original data model, the green layer that we're seeing there is what the project offices were seeing. As a whole, how are health centers doing? But the health centers came to us when the tool was launched and said, I need to know how I'm doing. I don't care how we're collectively doing. I need to know how I'm doing. And so we added a functionality that allows a health center to look at their specific footprint. So the same type of mapping we're doing for the medical schools and the residency programs, we're doing now for the health centers. And so you can see the cross-hatching on here tells me where Wake Health Services, where most of their patients came from in 2015. So we're looking at a core service area, ranking the zip codes, or ZICTAs is what we're actually mapping. So ranking ZICTAs by most patients to fewest patients and creating a footprint until we've accounted for 75% of their patients. And then you can look at what that ultimate question is, that service area overlap. So here I've added a second healthcare provider. In this case, I've added the North Carolina Health and Human Services Department. And where we have crisscrossing, cross-hatching, that's where both of these health center organizations are claiming patients that are part of their core service area. And underneath it, we're looking at the community use of the health center. So we're looking at both from a business sense, where do most of my patients come from, and from a community sense, where are we relying on health centers? And you can see all of that information in one map in the UDS mapper. But that wasn't enough. They also needed population data. And so we added a tool called Population Indicators. And this particular tool allows us to turn on different indicators at the ZICTA level and compare them. So what I'm looking at here is low income. And I've set, if you can see on the far right, I've set some sliders at levels that I'm interested in. So I see, and I did some work outside of the UDS mapper to find out what the rate of low income is for North Carolina. So I've set my slider to 38%. So everywhere that's orange exceeds my benchmark for low income. These are areas that have rates of low income higher than the state average. And everywhere that's pink, just plain pink, has rates of low birth weight rate higher than the state average. And then everywhere where I see this sort of salmon-y color, that's where both rates exceed my benchmarks. I can't say that it's the low-income people that are experience the low birth weight, and that the low birth weight people are the people who are low income, because I'm a good public health person. I just know that both of these indicators are high in these areas, and it's going to help me pinpoint services. It's going to help me create programs. I can compare my patients to these areas. Are my patients coming from these areas? Are they at risk for poor birth outcomes? I can look at a lot of different, these data a lot of different ways. The indicators themselves, the top 6 come directly from the American Community Survey, so they come directly at the ZICTA level. The bottom ones, all of our health-related data, it was important to HRSA that we keep everything at one geography. So we do have an estimation methodology that we use to get all of our health-related data to a ZICTA level. So those are all our simulated estimates. As I said, the uniform data system itself is unique and revolutionary, but the data system is dated. It began pre-EHR, and so it was being reported at an organization level. Now that we have EHRs, it could be reported at any other level, and they haven't gotten there yet. So we're limited in what we can show in the UDS Mapper by how the data are reported. All the health centers do have an EHR and a patient management system, so there's no reason we can't look at the data in other ways. And so we're doing some research on what that could look like and how those data could be aggregated. Just to sort of round off what we've been working on. So I told you we sort of started with wanting to see data on a map and letting the world see data on the map and share their data. And then we went more into the health workforce field, and then we went into more social determinants of health and health access. And where the health policy world is now is looking at quality, changing payments, to match what's actually going on in healthcare settings. And so social determinants of health and the marriage of public health and healthcare are really hot topics now. And what we've developed is a tool we call community vital signs. We want to take the information, those social determinants of health information, and get them into the EHRs. So no more data extraction and then do your research outside of the EHR. Let's get all that information into the EHR. And we're working on the research now to sort of figure out, okay, the data are here now, what do we do with them? You know, is it the physician that needs to see all of this information, or is it something that's better looked at by healthcare administrators? Is this something that the nurse needs? And what does it look like when they see the information? You know, there's some statistics out there about how many facts a brain can handle when making a decision. I think it's around 4 or 5. And there's so much information that's being added to medicine. We already had your regular vital signs, and now we've added the human genome. And now we're adding all of this community context information. How do we take all of that and view it at the same time to make the best treatment decisions for patients? That's to be determined. That's research that we're still working on, but it's definitely something that we're getting our toes into. As I mentioned, we're currently on HealthLandscape version 3, which is built on Flash. For those of you who are techies, you know that Flash is experience a lot of disfavor and is going out of style. So we're having to move everything over to JavaScript. The UDS Mapper already has a limited mobile version, which is built on JavaScript. So this is sort of what the future of HealthLandscape will look like. But we're on our way there to get it to all users and multiple platforms so that they can always access these data. So I thank you for inviting me. If you go to healthlandscape.org or udsmapper.org, you can find a link that will take you to a page with many more tools than I talked about today. All of the tools that are listed there are free and open to the public, so I encourage you to use them. My official role is user support and training, so if you have any questions, feel free to reach out to me. We'd love to hear how people are using the tools. That helps us build use cases and build new tools. So thank you very much.
Hello, I'm Philip Summers with the Wake Forest School of Medicine, and I really wrote down her idea of how many things a brain can hold, and you actually can accommodate more through relationships, right? Like things that you understand, and then your body, your mind relates them. So I'm going to do something. I'm going to go off script a second here. I'm a person coming into space, you're your space, coming into his space. I want to see this.
Is it pushing your feet?
The reason I'm doing this, right, is a visual aid. These guys won this award. And the reason I think that's important is because they did it through collaboration. So Joseph and Jason invited me to come because I'm at the School of Medicine, but we collaborate with them, right? I didn't win that award. I'm bragging on him. But the point is, we know local places, and local places have geographies, and you don't need fancy maps to know where the wrong side of the tracks are. But Map Forsyth has done some great work in our community showing where the preponderance of blighted homes are, where theft is occurring. And that's been a powerful story that they've been telling in our community that's galvanizing local nonprofits. So I did all that to say we're working together, and I think that's sort of what our talk today is going to be about. So we didn't really prepare that many comments. I was afraid, though, that I was going to get here and you guys were going to think I didn't really like maps. So like this morning at 6 a.m., I created a quick presentation. But it's really just like a couple slides to say my background's in public health, but I think maps are cool too. So I don't even, oh, it did that silly thing, but he told me if I do Windows P, I can go to duplicate. Okay, so I don't know how well I'm going to be able to drive this thing, but this is what happens. Shows you right. You shouldn't do fancy things, but let's say allow here. Allow. What is this doing? Oh, well. We can scrap it all together, but you might know the CDC recently, this is a CDC map that came out, but what this is showing you is the geography of health disparities in our community, right? So this wasn't a local geographer, but because all of us can be in these disembodied clouds and get all this data, this does line up perfectly with those of us who've lived in the community a long time. We know where the housing projects are, where people have been redlined. And so you can see this is obesity rates through the CDC. Let me try to go back really quick. This was just some work I did. I don't understand why this won't go away. What if I hit enter? I'm clicking on this. Yeah, that's okay. Well, it was just some work I did on the hidden nature of farm worker camps. So again, one reason it's easy for me to like celebrate what Joseph and Jason and them are doing in Map Forsyth is because I think there's a really great movement afoot that's like making mapping more accessible. And the reason that's important is then we can tell stories together, right? Like, so I'm in what's called the Clinical and Translational Science Institute, and I really realized part of my job is translating things. And it used to be that maps, just in their very nature, are great at telling stories, but only certain people used to be able to tell those stories because the technology was like sequestered into this like specialized field. This is kind of a listing of open source things that I use to create some of the maps you're seeing here. I will say that this map was really cool because it was supposed to be showing you like where some people in our community are from, right? Like we have a wonderful Hispanic community in Winston-Salem, and so this is showing you like where they come from in a study that we did. So I'm going to be quiet because I think we're going to try to have a lot of dialogue, but we are really interested in maps, and we're so grateful that we can partner with people like Map Forsyth and the health department to really take what we know locally and make more powerful products.
What do I do? It's on?
Yeah, just don't put it right up to your mouth.
Hello, everyone. I'm Lavette Miller from the Department of Public Health in Forsyth County. I'm both an epidemiologist and a geographer, so I love maps. From the health department perspective, though, it was important for us to partner with Map Forsyth because we wanted to be able to better visualize where health issues were taking place. We do have limited dollars to implement programs, and we wanted it to make sure that we're using it, as effectively as possible. We're targeting the right people. What's great about it, using maps and GIS, is that it allows us to broaden our vision of population health beyond the population, to look at socioeconomic factors and to look at their physical environment. Basically for us, public health does not take place in a vacuum. It happens in specific spaces over time. GIS allows us to use both temporal and spatial scales to understand what is happening and to be able to develop better plans. So we partner with Map Foresight, and it's been a lovely partnership. Thank you.
So first up, I want to open it up for questions for any of our panelists, from anyone in the audience. Sure.
So I have a number of questions, but I won't hog the floor. I'll ask one at a time and see where it goes. Philip, I was really glad that you showed that map from the CDC. That was my first question that I want to ask. The organization I work for, the Trust of Public Land, does a lot of work on social vulnerability and equity and trying to use health data at the local scale, which has been really difficult to find. And for those not familiar with that CDC data, it's for 500 cities, 500 largest cities, and it's like 27 or 8, maybe 30 variables looking at health at the census tract level. So a really valuable data set. So my question is whether any of you have taken a really good look at that. Obviously, Winston-Salem and Greensboro maybe, or whatever the largest cities there. In Forsyth, I'm not familiar with that. And how does that compare to your local data? Is it comparable in terms of what it's identifying?
Well, I want to jump in, but I also want to make sure Joseph has a chance to answer this. He had mentioned that his boss said, you guys do cool things, and his boss is Dudley Watts, who serves on our stakeholder advisory committee. So we've got a lot of good synergy. So it was a couple of years ago they started really mapping some of these same type determinants, and so they have things absolutely local data, just like what you're talking about. And I've enjoyed looking at their maps. When these CDC maps came out recently, I was like, tells the same story. And so it was absolutely validating on what we know about the social determinants of health. So I guess that was a long answer to say yes. I mean, because these guys have been doing some of that work, it wasn't like a shock. I mean, I do a lot of work like in anthropology type settings, and so there's this idea of the windshield survey. Like you have a good idea of what's happening in your environments, but I said that to say, I was using those CDC maps recently. I'm consulting on some infrastructure improvements that our major medical centers can what's the word I'm looking for? Considering. And it's like, it's just really powerful when people who aren't used to looking at maps and don't understand the geography of health in our community, when you say, well, that project that you're considering is like essentially the spine of health disparity. So the way you go about that development is going to be crucial for either perpetuating further disparity or including people in our community who are currently feeling marginalized. So those are just ways we've used that product, but absolutely it does match up with the work they've done.
So yeah, Philip's right. Thank you. So we've been working on a project for a few years now where we have 26 different variables that we're tracking, and some of them are tax related, some of them are public health related. And then so what we do is we create hotspots for each one of those layers, overlay them on top of each other, and then we start to find places where in our community we have multiple issues with these 26 variables. And, you know, some of these places have almost all the bad stuff from 26 of these variables in certain areas. And so, you know, we've been doing that. Then I know UNC Chapel Hill had done a study using census data, and here again it lined exactly up with what we were doing at the address level, and then CDC information came out. And so it's nice to be validated, but here again it's nice to have all those different things here again. Because sometimes, I mean, we all work in GIS, and we know that sometimes people say, well, you can manipulate that map to show whatever you want, those kind of things, right? So it's nice if you do have some validation through other resources and, you know, things that aren't even part of our little group.
Sorry.
just to throw it out there, we did take all the data. HealthLandscape does have a 500 cities mapper that does the same sort of thing that I showed you with that population indicators tool. It allows you to overlap some of those variables. And the information in the population indicators tool that I mentioned is our simulated estimates to the ZICTA level. The geographer who developed the methodology for CDC is our former geographer, and he's given us the code. So our estimates for the ZICTA level will be using the same methodology as 500 cities. So look for those data in August in the UDS mapper. So.
We're supposed to repeat the questions. So do you have a...
Yeah, so can you give us an example of a project that you worked on together that resulted in data or in conclusions that led you to, actually making changes on the ground in people's lives?
Are you talking public health projects?
Yes.
Okay. Probably one of our biggest problems in Forsyth County, health-wise, are STIs. We've
Sexually transmitted infections.
Yes.
When we work with Map Forsyth, it's both public and private viewing, basically. So for public maps, STI is kind of a touchy topics for neighborhoods. So while we're okay and we have an agreement between us that certain data can be done at the zip code level, we're fine with it. For planning purposes, we do ask for it at the neighborhood level. It's much more, precise. We've developed our posse program where we go out and test in particular neighborhoods. And so we don't have a spike in STI confirmations, but it's probably due to us doing greater testing. We're expecting in another year or two to see that number stable or decline because we're now also treating and it's for free. That's probably the one that comes to mind immediately. We do have several others that are in the pipeline, dental and other issues.
So I can touch on that a little bit too. So obviously public health data is you got to be careful with it, right? You just can't throw it out there. And so one thing we actually did with the public health department is we actually have a memorandum of understanding between us. And in that, we actually laid out how we're going to accept data from them, how they'll give it to us, how we keep it secure. I mean, we laid out everything in that. And then also, there was I'm sorry, I don't remember the name, there was a training that we were required to do.
Yes, it's the one for human population researchers. So typically you would do the one at NIH or out of University of Miami. And I was probably very mean in asking them to go through it. But it was important for me that they understood where we're coming from as public health researchers. That it's very serious stuff when we're talking about touchy data.
So, no, you're good. So how our office is set up, like I said, we're an enterprise department, but we have our drive that where we do all of our work is locked down just to the 6 employees and a couple MIS IT guys who obviously support it. So we have all the secure servers. We even, every year we do HIPAA training with our MIS IT department, so we're always included in that. And I did require all of the staff, even though all the staff do not work on the public health data, to go ahead and do the training since they potentially could open up one of the folders and see the data and those kind of things. One thing we do is as we work with any kind of public health data, whether it's with nonprofit or in-house department, and they want us to geocode things, we say just give us the address and create some kind of unique identifier. We don't want to know anything else. We don't want to see anything else in there. And that's one of the ways that we kind of secure and keep everything safe. We don't want to know names. We don't want to know anything else. And then, two, once we've geocoded it and actually run the hotspot analysis and any other analysis that they want us to do, we'll go back and that original data, we destroy it, we get rid of it. We don't hang on that. We hang on to the end product and notes about how we did the analysis and those things, so if they ever come back to us and want it done again. And we recently just purchased an external, like a thumb drive, flash drive. It's secure, it actually has a code on it. You put a code in it, and so I'd never seen one. It's really cool. And so if we drop it somewhere, if somebody tries to figure out the code, it actually wipes it clean. And so that's one way we transport it. Literally, we're on the 3rd floor, they're on the 4th floor, and we'll still put data on, these kind of devices and things like that, because here again, who knows? I mean, you might be walking up the steps and drop it or something. So it took us a couple months actually to get the MOU in place. We were back and forth, talking about the different geographies and all kinds of things, but myself, the public health director signed off on everything. And so far, it's working great, but I think it's very important. So if you are a local government and you're looking to try and create those partnerships, I think a key is to create that trust. Because if that trust is not there, they're not going to come to you and say, hey, we'd like for you to work on this project. And two, part of that agreement, anytime, like I said, we have a couple other projects going on, and so if we want to use any of those maps, final products or anything, we actually have to get permission from Levet and others before we can use them in any kind of way.
So I'd add one point. I was thinking coming in, my very long drive from Winston to Raleigh, that what was so important about our discussion. So I'm a nervous person when it comes down to people's data, people's information. But I think communication is key. I was thinking back to our back and forth. What was impressive to me at our first meeting, and everyone laughed after the meeting when I said, I think we'll be able to work with them, because I'm not a good trusting person. But they were open to communications. At no point did they say, we don't want to answer that, or that's not an issue. They basically took all my concerns, and there were a lot of them listed on paper, and they were very patient in hearing what our concerns were from the public health standpoint regarding the different kinds of data that we deal with, and how it would be managed, and who would see it, and how it would be shared with the community, who would get to see it, basically, or who would have control over it. How could they use it? At no point were they dismissive, I suppose, of our concerns. That to me was very impressive, and that opened the room for more dialogue. When that happens, when Map Foresight say, no, we're not good on this part of the memorandum of understanding, we're open to hear their views now. I think if it began with Map Foresight being dismissive, and I say Map Foresight, it's those guys that I worked with, and Jason, and they took it seriously. Communication, I think, open communication was the most significant aspect of the negotiation. That was impressive. Thank you.
Following up on a couple of things you just mentioned, can you say more about the sort of the neighborhood population communication with the data outputs? So if there's a mutual agreement about who can use the aggregated, the identified information, let's just say they're going to have outputs for census tracts, and you identify areas of concern based on the map work, and what happens then? Do you make a point to share that information with community groups or neighborhoods, specifically residents, before you share it with other agencies or with nonprofits or other actors whose information you didn't?
So when we ask Map Foresight, I'm sorry, repeat the question.
No, we're supposed to repeat it to the mic.
I'm sorry.
So I'll do it for you. The question, the gist of the question was, how do you disseminate your findings back to the neighborhoods, and how do you involve the neighborhoods in the whole process?
Okay, thank you. If the mapping is done at neighborhood level, we're more discreet in the group that it is shared with. We're doing it with that particular neighborhood, not say the entire Winston-Salem, groups, shareholders. or stakeholders in this, I'm sorry. But if it's a general mapping regarding crime or births, and we're looking now at resources, potential resources, or need for resources, that's different. We are required, the health department, accreditation purposes. Maybe we wouldn't have done it otherwise, but we are required to share that information in at least 3 forums. So we can do it by bringing in stakeholders, or we can do it as well as going out into communities and holding public forums. So it all depends on what it is we're mapping. Yeah.
So it's not in my current role, but in a previous role in Houston, working with an organization that had, it was a funding organization, wanted to do work in the neighborhoods in Houston, did a lot of data work before going into a neighborhood, and would go in and say, we see that liver disease is really bad here. We want to help you address that. And there was always a time immediately after that where we would say, but what is your concern? So I think that was the most important part of the work that we did in those neighborhoods, was to say, what is your concern? And so in this particular neighborhood, it was a bunch of Vietnamese immigrants who lived in, it was called the Vietnamese Villages. It was some low-rise garden-style apartment complexes in Houston. And every time it rained, in a swamp, the courtyard would flood, and it would bring sewage up into the courtyard. And so they started working with us on the liver disease issues as soon as we brought the city in to say, we need to get this sewer line fixed. And so I think getting, before any sort of project to go fix neighborhoods, we need to make sure we're listening to what the neighborhoods say their real issues are as well.
Okay, I'll ask my second question. So as far as Jennifer, so with the department prescription program that's growing quickly across the country, organization, part of that was the National Park Service, what they're trying to put together in the Washington area. Yes, the answer is no, but is there data downloadable off the UDS site? And if not, will there be in the future?
So the UDS mapper itself, all the data are downloadable, but not probably in the format you want. You do have to select your geography on the map, or there's a number of ways to select your ZICTAs, and it is all ZICTA based, and then you can export your file. So you could fairly quickly, probably with an intern, have an entire data set for the United States, but it's not going to be a simple download one file type thing. Most of the mapping tools that we have, the data are available for export. We also link to all the original data sources if you want to go to the data source itself. The limitation on the UDS mapper, you're only going to get the processed data. You're not going to get the raw data behind it. And the location information in the mapper comes directly from the HRSA data warehouse. So we recommend going to them for the location information. I'm sorry, I didn't repeat the question, even though Philip said repeat the question. So it was just, can you get the data out of our mapping tools? So yes, you can.
Go ahead. Yeah.
My question is toward Joseph, I think. You mentioned there are 26 indicators or so that you've come to rely on in the work with public health. And I wonder if you might just say a little bit more about how would you characterize those, what are the sources that you derive from?
So the question was in regards to Map for Size project of distressed areas, what we call it, and the 26 different variables. How do we keep them updated? What are the sources and the like? So it's like pulling teeth, right? So These 26 different data sets come from multiple departments. So everything from public health, DSS, tax, planning, code enforcement, so on and so forth. And so each year, our Jason Clawfelter, our analyst, reaches out to those different departments to say, okay, it's our annual update of this data, so we like to grab it in year chunks, right? And the level of it is to the address, so we have everything at the address level. So obviously some data is more sensitive at that level versus other. Because of that, the DSS and public health data, we have to go through a couple extra steps to secure it, make sure anything we produce is, doesn't identify people and all those other things. Other things like delinquent taxes or copper theft, all those kind of things. But like I said, what we do, the whole process is we start with the address points, but then we do the analysis from that. And so we never ever really show the address points. Sometimes we'll have if Jason's doing a presentation, he'll have a slide just showing, to make sure people understand exactly what we're doing, address points of delinquent taxes in the county, something, that's put in the newspaper, so it's harmful to show, or it's not harmful to show on a map. But then everything else is in a format of hotspot, heat mapping, and things like that, so there's no way to identify anything. But yeah, it's, and the thing that helps us, the city and county manager are really on board with it. And so all the departments know that. Now, even though that may be the case, there's still times where we have to email a few times, call a few times. I bump into them at meetings and remind them and things like that. But for the most part, people are pretty good about getting us their data. Yes, sir. Sorry. There's two parts there.
This is a little more improv off that question, but I actually live and have lived the last 7 years in one of the distressed areas that's identified in his map, and so I'm really attuned to this labeling of place, like this is a place that's not worth dignity, because indeed my neighbors and my friends reside there. And so I think I share that to say it's been really powerful as a public health practitioner and someone who's interested in improving the health of our community to realize and to say time and again that as we get proximate, as we get close to the mic, I don't know, but as we get closer to the problems, as we understand them better, our research is better, our policy solutions are better. We're currently really working on advocating for transit improvements, because you'll also notice that the transit-dependent riders are along the eastern side of 52, and we're having a lot of access problems to the nice grocery store. So some of the work that they've done has included food deserts and transportation access. So because a lot of people are using good science and their big hearts, I think we're working towards better solutions.
What else do we want to ask? Christian?
I'll ask one for Joseph. Those addresses are clean.
So the question was, are those addresses clean? They are after Jason Clawfelter cleans them up. Spends many hours cleaning them up. That is the biggest issue. Getting data sets in, usually spreadsheets and things like that lots of times, and the addresses are all over the place. Now, doing this project, I think some of the departments are getting better, and we need it in a certain format so we can geocode it and those kind of things. One thing we're trying to do within our county, we actually just did a big addressing project where we went through and we're cleaning up address points and things like that, and we have a master address repository, so we're trying to get people to use that. So in their systems, they're not hand typing stuff and messing up the addresses. But that, and Jason might differ with me. I think that's probably, when he's working on this, that's probably 90 to 95% of his time, once he gets that data, is going through it, and just making sure the addresses, are there. And then, sometimes people put in P.O. boxes and things like that. We always remind them, hey, we can't geocode that. We're not going to, so, no.
So, in a follow-up, so if they're not clean, then you don't go back to the source, you go to
So the question was, sorry, I don't want Philip smacking me here. If the dress is not clean, do you go back to the source to have it cleaned, or how do you make sure it's clean? You want to grab that, Jason, or I can, either one.
It depends on the margin of error with the data set. I mean, if we go through, we'll run it through certain steps that we'll take. Generally, just every data set that we get in, we do the first glance. And then, depending on how many of those are still fall outside of our tolerance, depending on the numbers, we're looking at 100 instances, we want pretty much 100%. If we're looking at 90 to 100,000 records, as we may get from DSS or somewhere, a few thousand, we're okay with. But depending on the set, that tolerance level, we will provide that report back to the data provider, and just let them know X number couldn't be identified. There was a PO box. There may be fall outside of the county, several zip codes across the county boundaries and stuff like that, and still have a Winston-Salem address or whatever, so things that fall outside. We do our own geocoding in the composite locator that we built, rather than using an Esri or Google or something like that, so that we can get that error report back and know what may not geocode. Sometimes it's not as bad. A lot of the data sets, in particular all the crime data sets that we get, are pushed to us out of the CAD environment, and they do have a geo-verified XY coordinate. So those are good to go. I don't have to worry about those things. Typically, it's the big data sets from DSS, public health, things like that.
Okay. So you guys are just working with the addresses, you're not working with patients, you're not doing any kind of research.
No, we just work with the data. We don't work. Yeah.
I laugh because Christian works in my office, and geocoding patient data is a big part of what we do.
So
Statewide, not just one county.
Our issue is a little bit different. The health centers are reporting their data for a federal report, and a lot of time they didn't put a whole lot of thought and effort into that until it was made public on a mapping tool. And so we have found that our data cleanliness has improved once those data started to be used for something. So before, it was just data that were being reported in. They had no idea how the data were being used. It was sort of this black box. And then as soon as those data hit the internet, they were, wait a second, that's not where my patients come from. And they started working on cleaning their data at the health center level. So,
On that theme, since I do work for a major medical center, it's been fun being in the Translational Science Institute, because as we've brought on informaticians, she alluded to this idea of having social determinants of health in the electronic health record. She said EMR, but because I translate things all the time, I don't know what people know. And so this idea of where you are coming from, we have, I think, some romantic notions of a doctor being from your town, and so they would know about your town, but in a big city, they might be there on their residency, and they've only been there a few months, and they don't understand the geographies that people come to. So it's been really interesting for me, as someone who's concerned about how place influences your health, to see that we have started to build that into our EMR. Now, right now, it's on the back end, which is to say we are geocoding our patients' addresses, and we're pulling in the census level data, and we make that available for investigators through what's called I2B2. I think I'm using the right analogy. I can't tell you what that means, but essentially it's this data warehouse where if you say, I want to see our diabetes patients, now you have variables not only about like where they're from, but things about their neighborhood. So there is a really interesting confluence of GIS and information science.
and just sort of on that topic, we've just submitted an abstract for APHA that's looking at this sort of physician understanding of what area they're serving. And so we took this concept to physicians in a multi-practice setting and said, here's a map, where do your patients come from? And compared that to where their patients were actually coming from. And so they're sort of west of Washington, D.C. They thought most of their patients came from Washington, D.C., and actually it was their patients further west in more rural, less resource-heavy areas where their patients were coming from. And it was a very much of an aha moment for them. They thought their patients had access to all this stuff, which they do probably at work, but not when they're home. And so that sort of concept, opening up that idea to the physicians was really eye-opening for them.
So one thing that we've done at the health department, we've implemented this year a policy that communicates to staff who may contact MapFor staff directly, what the data should look like, basically how should it be laid out, what can be shared. And so we're hoping that you'll see improved addresses. It comes to me as a final check before it goes to MapFor site. Before anyone would try to do mapping on their own, we've discouraged that. We prefer that one entity, MapFor site, does it, because anyone can create map and they don't even know what they're creating, or if it's actually saying what they think it is saying. ArcGIS works for everybody if you have a Windows-based computer, at least for me. So that's how we've dealt with that. We've dealt with having better addresses, but also controlling how the data is shared and in what format. And it's to lessen the work on MapFor site once they get it from us. Because most times we have very tight deadlines when we want that map to be done. So.
Any other questions? No? I'd written some down, but I think they were covered in the first two questions that were asked, so that's all I have.
I don't want to stand between you and early departure, but I will just dream, since there's geographers in the room and I'm not one. And I'm not a physician, so this is probably way off base, but to me, when we think about that encounter with a patient, I think because geography tools are powerful now, I have often been dreaming of things to like humanize people in that encounter, so things like their photo, but then also maybe like aerials of maps, like with their, right, so you're in their record, you know their address, now you've pinned their house on a map. Can you show like what the racial composition, right, so like are they in a minority predominant area, are they in some sort of distressed area, something that would, again, be a picture that like helps paint. I think it's fun to dream about that. I think one of the big ways that you could err there is you definitely, we're trying to teach more and more humility to physicians, right? Like you can't know everything, you can't be an expert. Like just because they have this map doesn't mean they're going to be able to perfectly diagnose things. But again, I just thought I would throw it out here as we're dreaming about, and your APHA abstract made me think about it. It's like, how are we going to like respectfully use all this data that we have access to?
So I don't know if any of you have had the opportunity to go to Health Data Palooza in Washington, D.C., but a couple years ago, Farzad Mostashari, who's in charge of, I think, Adelaide, I never say it right, healthcare, brought up this sort of idea. How do we bring this information in a way that's not cookie cutter? So if my main issue is diabetes, I need to see the community context that would help me with my diagnosis, as opposed to asthma, as opposed to rehabbing from an orthopedic injury. So we need to think about this in a way where we're thinking about the patient and not just an easy way to get these cool data into a health setting. We also need to make sure that they are used across the healthcare team. So it's not just the physician's responsibility, but it's the front desk staff, it's your medical assistant, it's everyone along that sort of care continuum. We sort of have envisioned what we're thinking of as a 3x3 table that would sort of help map risk for the doctor or the medical assistant. So this person's physical vital signs are low, and they live in a resource-rich neighborhood, and they have lots of social support. So I'm going to, take care of this patient as best as I can, but I'm going to spend more time on the patient who has high needs according to their physical vital signs and concerns, and high needs along that social community context as well. So just some sort of simple visualization tool that you don't have to take in, 20 aerial images or 16 new pieces of data. It's a quick visualization thing. But like I said, we're doing this at the same time we're doing the research. So it's all changing very rapidly, but that's sort of what we see as something that could take in relevant data to you into something that would make a difference at that patient visit.
So just as they were talking, I just wanted to emphasize, we're a GIS department, right? I'm not a medical doctor, I'm not public health. And so what we produce, we give back to them to let them interpret what it says. And that's how we work with every department, whether it's tax, whether it's planning, whatever. They are the subject matter experts on that. And so for us, we produce it, we'll sit down with them, we'll explain how we came up with what we came up. And lots of times we always have pre-map meetings where we sit down and say, okay, let's talk about what we're going to do here. What type of data, is the data available, and these kind of things. And then we let them know kind of the process we went through to come up with what we had, and basically we kind of pass it back off and say, okay, you interpret it. And once they interpret it and they have that out there for folks, that's the point in which we're comfortable and she's comfortable for us to push stuff out within the context of Mapper. So I wanted to share this. This just made me also think of a really cool quote that our county manager actually said. He said, GIS is the tool that allows us to gain a much deeper understanding of our community challenges. It can serve as a dashboard to let us know how we're doing and as a testing site for potential solutions. Data tells a story, and stories are imperative if we are going to build effective solutions across what seem to be almost impossible political and social boundaries. If used effectively, GIS can be the master storyteller. And so but we also have to be careful with that, like I said.
Any other questions? Okay, well, thank you, everybody, for coming to the session. Yay for you for sticking it out to the bitter end. Thank you for coming to the conference as one of the organizers. We really appreciate it. We work hard to do it for you. And big round of applause for our panel.